Well, good morning, everyone. My name is Amar Kalou, and I'm one of the cardiac electrophysiologists at Mayo Clinic. I'm joined by my colleague, Dr. Arman Argami. He is a fantastic adult cardiac surgeon with a special interest in robotic surgery as well as hybrid arrhythmia surgery, which we'll focus on for the webinar today. I have some conflicts that I just want to bring to your attention. The learning objectives are as follows. We're going to identify the importance of atrial fibrillation. We're going to discuss the limitations of catheter ablation for the treatment of persistent and long-standing persistent atrial fibrillation. And then we'll discuss some of the hybrid options for the treatment of patients with persistent and long-standing persistent atrial fibrillation. Now, as we go through, you may think of some questions that you would like to ask. Please send them in, and then we'll discuss those afterwards. So we'll start by discussing atrial fibrillation and the problem that it presents in our population. As you probably know, it is increasing in prevalence. These are two curves showing the overall prevalence of atrial fibrillation across time, and you can see that it's gradually increased, and it's estimated that it will continue to increase over the next 20 to 30 years. You can see that men are more commonly affected by atrial fibrillation than women. Part of the reason for this, that we see the increase in atrial fibrillation, is that the population is aging, and you can tell from this curve here that there tends to be an inflection point in terms of the prevalence once people hit the age of 65 or so, whereby it becomes much more frequent. In addition, as a population, we have a lot of obesity, and that continues to get worse. And if you look at these two maps side by side, on the left we have the atrial fibrillation prevalence map with darker red demonstrating higher prevalence of atrial fibrillation. And that correlates very well with the obesity map in the US, whereby darker shades of orange and red are higher rates of obesity. And so that is one important factor that continues to drive this arrhythmia. Now, the newest atrial fibrillation guidelines that were released by the ACC, American College of Cardiology, Heart Rhythm Society, and American Heart Association talk about these AFib stages. So they've tried to make this somewhat mirror stages of heart failure. And the classification of atrial fibrillation in terms of paroxysmal, persistent, long-standing persistent is the same, and we'll talk about that in a moment. But they've introduced these new stages of stage 1, stage 2, where stage 1 is patients who are at risk for atrial fibrillation. For example, those that have some modifiable risk factors such as obesity, hypertension, obstructive sleep apnea, excess alcohol, etc. And then those with non-modifiable risk factors, so genetics, as we discussed, males more likely to have atrial fibrillation than females, and then advancing age. Those with pre-atrial fibrillation are those in stage 2, whereby they have any cardiac structural abnormality that may increase the likelihood of having atrial fibrillation. And then as we discussed the stages of atrial fibrillation once you actually develop it. So paroxysmal atrial fibrillation is self-limited atrial fibrillation that occurs within 1 week. Persistent atrial fibrillation is anything that lasts greater than 1 week. And if it's continuous for more than 1 year, it becomes long-standing persistent atrial fibrillation. Permanent atrial fibrillation is when someone, namely the physician and the patient, has made a conscious decision to avoid abandon rhythm control strategies and instead focus on rate control and symptoms. Now, you will notice that across all stages of atrial fibrillation, it is important to treat the modifiable risk factors. So any of these things that we've listed should be optimized. And then, of course, once patients have atrial fibrillation, to determine the individual's stroke risk and initiate therapy if appropriate, and of course, treat the symptoms. Now, in terms of treatment for atrial fibrillation from a rhythm control strategy, catheter ablation is very effective when we're dealing with paroxysmal atrial fibrillation. And the mainstay of that is typically to perform pulmonary vein isolation. So pulmonary vein isolation involves a procedure whereby we electrically isolate the pulmonary veins from the left atrium. And the reason to do that is because the triggers for atrial fibrillation most commonly originate from the pulmonary veins. In patients with persistent atrial fibrillation, pulmonary vein isolation on its own is typically not enough because in addition to having triggers, they have underlying substrate abnormality. And so in this situation, we may be more likely to perform linear ablation to try and compartmentalize the atrium, a bit like what would be done with a maze procedure, for example. In addition, ablation of fractionated areas of abnormality within the atrium may have some promise, although randomized studies have never really demonstrated this to be universally beneficial. If you look at the ablation outcomes in the randomized studies in the EP literature, so here we have patients with persistent atrial fibrillation, and I've included various studies that have been performed to look at those outcomes in those who've had stringent monitoring for atrial fibrillation and those with somewhat more lenient monitoring for the recurrence of atrial fibrillation. And irrespective of which one you look at, you can see that the outcomes are somewhat tempered with a recurrence rate that is about 45%. So 55 to 60% of patients are arrhythmia-free at 1 year. Now, this is with radio frequency, and one of the biggest changes in our field of late has been the emergence of pulse field ablation. Pulse field ablation is a somewhat more selective ablation modality with less thermal impact than radio frequency. It has a more favorable safety profile that we'll mention briefly, but it has not been demonstrated to be any more superior in terms of efficacy compared to radiofrequency ablation. And this was from the Pulse AF study that looked at one of the pulse field ablation catheters and showed that the freedom from atrial fibrillation at 1 year was still only about 55%. So while it may be more efficient and safer, it's not more effective, at least in this latest iteration. And so in terms of ablation techniques, if linear ablation, fractionated electrogram ablation, pulmonary vein isolation is not enough, then adjunctive ablation may be beneficial. So this is where posterior wall ablation for the left atrium comes into play and potentially management of the left atrial appendage. Now, when we perform pulmonary vein isolation, we're typically talking about just isolating the entrance of the pulmonary veins into the left atrium. So if you look at this left-hand figure, we're typically just doing rings around the ipsilateral left and right veins. But the posterior wall of the left atrium is actually pulmonary vein derivative. And therefore, if we want to do a complete pulmonary vein isolation, we really should be including that in our ablation lesion set. And so one way to do that would be to do a line across the top and the bottom of our rings to isolate the back wall. We can do a line along the top and the bottom, or burn within the posterior wall itself to try and isolate it. Or this is slightly more difficult and less commonly performed. We can perform a ring along the anterior aspect of the veins and then go along the floor of the posterior wall, anterior to the right veins, and then go along the roof. So basically boxing out that whole posterior wall and the pulmonary veins. The difficulty with this is that it's very common to get reconnection of the posterior wall, and that's irrespective of which energy modality we use, whether it's radiofrequency, whether it's cryo ablation, or pulse field ablation. Though again, there is fairly limited data on this modality as yet. And then an even bigger concern is a safety one, and that's esophageal injury, whereby you can get a connection, as we'll show you in a moment, between the atrium and the esophagus because of overheating. And this is something that can occur with radiofrequency and cryo, though is much less common and to date has not been reported with pulse field ablation, which is one of the benefits of it. Now, when we've looked at the impact of performing posterior wall isolation in patients with persistent atrial fibrillation, in addition to pulmonary vein isolation, we have not clearly demonstrated any clear benefit. So this was the Kaplan study of 338 patients that were randomized to pulmonary vein isolation alone or pulmonary vein isolation with posterior wall isolation in those with persistent atrial fibrillation. And you can see that the Kaplan-Meier curves are essentially superimposed on top of one another. there was equal arrhythmia recurrence amongst both groups. Now, does that mean that posterior wall isolation is not effective? Not necessarily. If you look at this study and many other studies that have looked at posterior wall isolation, their reconnection rate is high, and therefore, even though we may have acute isolation of the posterior wall during the procedure, a number of these may reconnect, and therefore we may be at risk for recurrent arrhythmias. Now, this is the other concern that I had mentioned, is if you ablate more aggressively and get thermal injury of the esophagus, you may form an atrioesophageal fistula. So this was a patient that was referred to us after undergoing an ablation 3 weeks prior and had presented with stroke-like symptoms as well as fevers. And the concern, given that he had had recent catheter ablation, was for an atrioesophageal fistula. And you can see on this CT cross-section that there's gas within the left atrium. And indeed, the patient went to emergency surgery, whereby a clot was evacuated from within the left atrium and the fistula repaired. You can see here. Now, this was a study done a number of years ago that looked at the impact of posterior wall isolation in persistent atrial fibrillation. But one thing that was unique in this study is that patients came back for remapping irrespective of their atrial fibrillation recurrence or not. And only once they were demonstrated to have clear posterior wall isolation were they then assessed in terms of the efficacy of pulmonary vein isolation with posterior wall isolation related to pulmonary vein isolation alone. And so when they had demonstrated that there was durable posterior wall isolation on remapping, those patients were noted to do better long-term compared to those with pulmonary vein isolation alone, suggesting that if we are able to effectively isolate the posterior wall, then it may be beneficial in terms of outcomes. And so because of the limitations of catheter ablation for posterior wall ablation in patients and the potential safety concerns, hybrid ablation has been a very attractive modality for some individuals. And I'll pass it on to my colleague, Dr. Argami, to discuss the convergent procedure and some other hybrid techniques.
Thank you, Dr. Kulu, for that great introduction and the nice segue into this hybrid procedure. As you mentioned, because of some of the limitations in terms of ablating the posterior atrial wall, a new procedure needed to be developed, and what came along was a hybrid procedure, which by using a special catheter that uses a similar RFA ablation, but much higher power output, we are able to ablate the posterior atrial wall. This catheter is designed to be placed between the esophagus and the atrium and is insulated so the heat and thermal spread to the esophagus is minimized and allows us to much more effectively ablate the posterior atrial wall. The catheter is a 3 centimeter long catheter, and it's designed to burn or ablate the posterior wall in parallel lesion sets between the two pulmonary veins on each side. This procedure was designed to be done in a minimally invasive fashion with an incision at the subxiphoid area and access into the pericardium posterior wall to perform this using a camera. Now, we all know about the benefits of left atrial appendage ligation. This is the LOS 3 trial that came out a couple years ago, showing a 30% reduction in the risk of ischemic stroke in patients who had their left atrial appendage ligated during cardiac surgery as compared to those who didn't. And that's why the ACC and the American Heart Association have guidelines to suggest during cardiac surgery with patients with history of atrial fibrillation, amputating or clipping the left atrial appendage as class 1 indication. So most surgeons who were performing the hybrid procedure also combined it with the left atrial appendage ligation using videoscopic approach because they wanted to keep it in a minimally invasive fashion. So there will be 3 ports on the left side of the chest wall to perform this clip placement. Now we took that a little bit further. We added a fourth incision, but to do this robotically. By that, we were able to eliminate the subxiphoid incision, which was sometimes part of the discomfort and complications of this procedure. This is how the room setup looks like. A robotic machine is positioned and attached to the patient, and we're able to perform the procedure that way. Next, I'm going to show a short video of that. So this is looking at the pericardium from the left side. That's the phrenic nerve I'm pointing to. We open the pericardium below the phrenic nerve, a couple centimeters to avoid any injuries to it. You can start seeing the heart jumping in there. That's the left atrium in the view in the up corner. We extend the pericardial opening further towards the diaphragm and posteriorly. Now this is us looking at the posterior atrium. So the pericardium is down, the heart is up. We map, as you just saw the grid coming in, we map the atrium before and after the ablation, and we can talk about the benefits of that. Then we start the ablation in the atrial dome. Now, as was told, this is a hybrid procedure. We cannot get to the entire ablation lines through the left chests, but we can try to get as much as we can. So this is the ablation line coming anterior to the left-sided pulmonary veins. Here we go posterior and try to connect it to the posterior wall. The only part of the lesion we cannot create is the right pulmonary vein anterior aspect, which will be done in the second portion by Dr. Kulu and his colleagues. So as you can see, the visualization is much better here. I personally feel like so. Even though the catheter is fairly insulated, we put some saline in the pericardium to even dampen any warming of the esophagus. We have a temperature probe in the esophagus as well. And as you can see here, we can easily see the right inferior and right superior pulmonary veins all in one view. And once ablation is done, we put the mapping catheter back in there and confirm the ablation. As mentioned earlier, we do combine this with the left atrial appendage ligation. We use a clip. You can see here the clip is being positioned. The left atrium is fully engaged into the clip, and the clip is applied and closed under echo guidance to make sure there is no residual stump and no residual communication. And once that's confirmed, the clip is released and the device is removed. I do tend to close the pericardium partially and loosely to allow for a better anatomic position of the heart. Now, I mentioned that we do a map before and after. This is the picture of one patient we did a few months ago. As you can see, before we started the procedure, there was viable myocardium on the atrium prior to the procedure. Many of these patients who come to us have already had multiple ablations, so we want to make sure we have adequate viable myocardium to start with. Then the middle one is the mapping I did when I thought the procedure was completed, but you can see there's a residual viable tissue there. And we went back and ablated it again, and this is the final result. So I think it does help mapping the atrium before and after your procedure to confirm what you've done. So what are the results? The CONVERGE trial, which was a randomized clinical trial, came out. The results came out 3-4 years ago now. They randomized patients to do 2 groups. These were drug refractory symptomatic persistent AFib or long-standing persistent AFib. 150 patients were selected, and they were randomized 2 to 1. About 100 of them got a convergent procedure, which is the hybrid one, and 50 got the standard endocardial ablation. And they were followed for the first 12 months, then 18, 24, and then yearly after that to 5 years. The basic baseline characteristics of these patients were fairly similar, except for there was slightly more male patients in the convergent group, 78% versus 53%. Everything else was very similar. The result at 1 year showed that the patients who underwent the convergent procedure had better freedom from atrial fibrillation, 67.7% as compared to 50.0%. So this showed that the convergent hybrid ablation had more effectiveness in patients with persistent or long-standing persistent atrial fibrillation. But it did come with some increased complication rate of 7.8%, but no life-threatening complication. So in August of 2021, FDA approved the use of convergent procedure for long-standing persistent atrial fibrillation. This is not the only study that has looked at the efficacy of the convergent procedure. These are many studies that we've selected. As you can see, the efficacy ranges from 50 to 80% freedom from atrial fibrillation. Not every patient will be a candidate for this procedure. There are some contraindications. Access is one. We have to be able to get access into the left chest and into the pericardium. So any previous cardiac or thoracic surgery excludes the patients. If they had prior CABG or any other intracardiac procedures or any left thoracotomy procedures for lobectomies or similar. If the patient cannot tolerate single lung ventilation, like patients who have severe COPD, we have to deflate the lung, as you saw in the video, and the patient has to sustain oxygenation with one lung. Inability to complete the percutaneous portion, as I mentioned earlier, it's a hybrid procedure, so it does require a percutaneous intracardial ablation. So for whatever reason, if there is venous access issues, this cannot be done. And if there's need for any concomitant cardiac procedures, then it makes sense to just do an open heart surgery to deal with everything at once. This is an example that happened recently. A young female patient with long-standing persistent atrial fibrillation who also had a restrictive cardiomyopathy history. She had a very severe enlargement of the left atrium, as you can see in this CT scan, as compared to her left ventricle. And she also had a very thick left atrial wall. It was measured at 6.1 as compared to somebody with long-standing persistent AFib, which had at about 3 millimeter. So we decided to do this as an old-fashioned Cox-Maze procedure, and interesting on the pathology specimen of the left atrium, you can see it was marked myocyte hypertrophy and marked interstitial fibrosis. So this was a great example of making sure we tailor the treatment to the patients and not try to fit everybody in the same category. Now, as mentioned before, this is a hybrid procedure, so it does require an endocardial ablation, and Dr. Klue will tell us a little bit more about that.
That was very nicely summarized. As you can see from what Dr. Aragami just showed you, is that these are carefully selected patients, so typically patients with persistent or long-standing persistent atrial fibrillation. So the patient population that is really quite difficult to treat with conventional ablation otherwise. A lot of these patients have been in atrial fibrillation for a long time. That was maybe attributed or felt to be asymptomatic, but subsequently resulted in either a cardiomyopathy or progression of symptoms that when sinus rhythm was restored, patients felt better. And of course, given the latest data suggesting that even patients who are asymptomatic, that there may be beneficial outcomes to sinus rhythm restoration in terms of these hard endpoint composites, sinus rhythm may be worthwhile pursuing. Now, in terms of doing the hybrid portion, there are some institutions that perform the surgical and the catheter ablation portion in the same hospital setting, and so that may be, for example, the same day, whereby the surgical portion is done and then the catheter portion is done in the same day. There are other institutions that may do them during the same hospital stay, but different settings. So, for example, they would do the hybrid surgical portion on day one, and then a few days later do the catheter portion. We have always favored a staged approach whereby we do the surgical portion and then have patients come back a few weeks later to undergo the catheter portion. The reason we favored that approach is to allow for lesions to really settle, the inflammation to go down, and then see if there are any gaps to what was done surgically that would then need additional ablation that we may not have identified during the same procedure. One of the downsides of that, though, is that it would require a second anesthesia run. So what I'm going to show you is an example of a patient who has had the posterior wall ablated with the convergent procedure. And so this is what we call a 3D electroanatomical map. And it's a 3D electroanatomical map of the left atrium, and then you can see the pulmonary veins. Now this is color-coded, and it's a voltage map. So essentially what we're doing here is looking at the cardiac signal at each of the locations within the atrium and pulmonary veins, and assigning it a color based on what that voltage is. And you don't see the curve on this, the scale on this, but anything less than 0.25 millivolts, and in this case even less than 0.1 millivolts, is red, which essentially is scar, and we confirm there's absence of any signals in that posterior wall. Anything greater than 0.5 millivolts is purple, and that's generally healthy tissue. And so you can see after Dr. Argami had done his portion, the posterior wall of the left atrium had very thorough ablation from one end of the veins to the other side. Now you will note that it's not as high up to the superior aspect of the pulmonary veins. And that's not uncommon to see because we're limited by the pericardial reflection during the time of surgery. And so in some individuals, it's a bit lower down. In others, it may take you higher up, but you can only do what the pericardial reflection allows you to get to. And so here we had a very thorough ablation of the posterior wall. And this is what we call an activation map. So now the colors represent timing, and we're stimulating the heart from the coronary sinus in the left atrium. And you can see this is where it originates with the red color. And then you can see the wavefront spread across the atrium, but notice how nothing gets into the posterior wall. Again, showing you that we have no activation of the back wall. And the fact that we don't see anything on the endocardial aspect, so on the inside, when we ablate it from the outside, favors that this is a transmural ablation, which can be difficult to achieve with catheter ablation alone without having the concern of esophageal injury. So then to complete the hybrid ablation portion, we still do the pulmonary vein isolation. And so you can see these red dots are ablation dots, whereby we're encircling the pulmonary veins on both sides to achieve isolation, whereby there's no entrance of electrical activity into the pulmonary veins and no exit. Note that there are no dots in the area of red. Now, we verify when we're doing this to make sure that there are no potentials and no signals, but if it's already been ablated, that makes my day a lot easier and more relaxing because I don't need to worry about potentially injuring the esophagus, which can run right across that area of interest that we would want to ablate. So this was a different patient. You can see had a bit more scarring. You can see there's more or less purple in the areas outside of the posterior wall, but note how the esophagus ran right behind the left inferior pulmonary vein. But because of the hybrid convergent procedure that was done previously, I did not need to ablate in that area and therefore reducing the concern for esophageal injury. And so based on the latest ablation guidelines, surgical and hybrid atrial fibrillation ablation is reasonable to consider either as first line or as a subsequent procedure in symptomatic patients with persistent atrial fibrillation and those who are intolerant to antiarrhythmic drugs or prefer an invasive approach. But of course, it's important to discuss the safety and efficacy of all of the treatment options. And as Dr. Argami said, pick the one that is the best for the patient. And so to summarize, we've talked that atrial fibrillation is a growing health concern. Treatment options should be tailored to individual patients. And so some individuals may favor antiarrhythmic therapy, great. Others, catheter ablation percutaneously, while others may require more invasive approaches. Increased effectiveness is achieved with more invasive procedures, but again, it's very important to tailor that to the individual and discuss the potential risks and complications and anticipated benefits. But we've seen that hybrid ablation has demonstrated improved efficacy in patients with persistent and long-standing persistent atrial fibrillation. Now, on the left, you can see this figure or a cartoon that demonstrates the various invasive modalities for management of atrial fibrillation. And starting with the top, you can see the least invasive, and then going all the way down, you've got the hybrid convergent procedure. You've got thoracoscopic-based approaches, which we did not discuss, but can be performed in a hybrid fashion as well. And there's newer data in the last year or two, again, demonstrating the superior efficacy of that approach versus just catheter ablation alone in patients with persistent or long-standing persistent atrial fibrillation. And then, of course, the cut and sew maze, which many people, surgeons especially, have said is the gold standard for rhythm management for atrial fibrillation, but of course a very invasive procedure. And so you can see that hybrid options help kind of balance the risks and morbidity associated with stenotomy and maze surgery in that sense, but also help improve outcomes relative to just percutaneous ablation alone. So with that, I would like to thank you for your attention, and we'll answer questions that have come through. And please feel free to send them in as we go along.
Thank you, Dr. Kalu. So yes, as Dr. Kalu mentioned, please do send your questions. We're going to read through them. We already got a couple of questions. I'm going to read one. This one is for you, Dr. Kalu. Any comments regarding rate control versus rhythm control?
Yeah, I've never been a big fan of rate control. There was an old study called the AFFIRM study that a lot of people cite, which basically looked at patients with atrial fibrillation and randomized them to controlling the heart rate but leaving them in atrial fibrillation versus controlling the rhythm. And it showed that, and of course, anticoagulation for stroke management would be a standard. And it showed that there was no difference in hard endpoints, mortality between the two. The issue with that study, though, was done many years ago, and the evolution of catheter ablation and rhythm control management has improved significantly. Ablation procedures back then were taking a long time, 6, 8, 10 hours. Complication rates were much higher. Outcomes were not as good. There's been many more studies since then demonstrating that rhythm control is superior to rate control. A lot of the data is in patients with heart failure, but one of the studies I alluded to earlier was the East AFNet study that looked at patients with new atrial fibrillation, new defined as within the last 12 months, and basically randomized them to rate versus rhythm control. Rhythm control did not mean ablation. It could be cardioversion, it could be antiarrhythmic drugs, but that showed better outcomes in terms of hard endpoints of stroke, mortality, those kind of things as a composite. Again, favoring rhythm control. Now it makes sense, right? When you lose atrial contractility with atrial fibrillation, your cardiac output goes down. There's association with functional mitral and tricuspid regurgitation, all of these things that we're appreciating more and more now, even if a patient is quote unquote asymptomatic.
Yeah, that's a great point. I think there's some complications that are longer term if for patients who stay in atrial fibrillation that is hardly captured in these shorter term studies.
And one thing to add is the longer patients are in atrial fibrillation, the harder they are to manage, and that's why we sometimes have to resort to these more invasive approaches. We have good outcomes for patients with paroxysmal atrial fibrillation. It's just when they're left in atrial fibrillation, the remodeling that occurs, atrial enlargement, other comorbidities, it becomes much more difficult. But if there's any doubt, I think almost every patient warrants at least one try of sinus rhythm restoration to prove whether or not they really are asymptomatic. And even if they're not, I think there's enough data that in some individuals you could still justify going ahead with a rhythm control strategy. But again, it warrants a discussion with the patient.
Yeah, I like the fact that sometimes you discuss it with your patients. That how much improvement do you feel when after, let's say, your cardioversion or something that you were in sinus for a week or two, how did you feel in that 2 weeks, and that then you can compare to your, to that patient's self in a different setting.
Yeah.
So please do send your questions. We'd like to, answer as many as possible. I know the next one is a little controversial topic, but the question is long-term anticoagulation post-procedure, especially with left atrial appendage ligation.
Yeah. That's a very good question, one I was going to bring up if it wasn't asked, and so it'd be good to get your perspective. So a lot of patients who have the convergent plus procedure, which is where we do the posterior left atrial wall, and then you clip the appendage, as you know, ask, can I come off my blood thinner? And there's really not great data to say that the clip alone is going to provide sufficient protection from stroke that you would have had with continued anticoagulation. In fact, I mean, you showed the LAOS-3 study, which showed that continuing anticoagulation with the clip afforded better protection in terms of stroke prophylaxis compared to anticoagulation alone. But the question here is whether a clip alone is as good as anticoagulation alone. We don't really have that data. I would say it's, again, a discussion with patients most commonly. If they're tolerating the blood thinner, I would say stay on it. It kind of provides a belt and braces approach in terms of protecting from stroke, but it does give you some safety net if patients have, a high bleeding risk or contraindication to being on a blood thinner, that if the appendage is adequately excluded, that, they may have, reasonable protection from a stroke. One thing I would add as well is the reason we like clipping the appendage, and we've discussed this a lot, is not only from the stroke prophylaxis standpoint, but it may help in terms of atrial fibrillation management. The left atrial appendage can be a trigger for atrial fibrillation. There's variations in terms of how commonly that's the case. I think some data is over-reported where, they've said 20% of the time there's triggers from the appendage. I've not seen that in my own practice, but certainly in some individuals, I think it can be. And then it's also a substrate. And by placing the clip, we've demonstrated, and there's been some data on this, that electrically isolates the left atrial appendage. So not only is it mechanically excluded, but then electrically isolated, and therefore may afford some protection there. But what are your thoughts in terms of the anticoagulation?
Well, before that, I agree with you. The clipping has two purposes. I'm just going to summarize what you said. The purpose of the clip is both to mechanically block it so there's no clot formation or the clot cannot get out to cause a stroke, but also in theory, and we have shown that it also electrically isolates the left atrial appendage that could potentially be a source of triggers for atrial fibrillation. In terms of anticoagulation, I usually defer to you, but I agree. The fact that these patients, hopefully will be in sinus rhythm and they're missing their appendage, and they're, I know many of my patients would like to be off the anticoagulation, but again, we're still working on the data. I don't think there's strong data to support one way or the other. It should be, again, a discussion between the patient and their provider to make the decision, understanding the risks and benefits of both approaches.
Yeah. And one thing I'll add as well is we didn't really mention it because it was beyond the scope of the talk, but the Converge study that you showed, which actually resulted in the convergent procedure receiving FDA approval, or labeling, I should say, for long-standing persistent atrial fibrillation, which is the only approved labeling for procedure right now, is they compared just posterior wall ablation. Now, there are, it's an important study. It answered a question that needed to be answered. The comparator arm was not a like-for-like approach, even though it was catheter ablation. It was just a roofline, so they never actually tried to do posterior wall isolation. But that was just posterior wall ablation with the converged EpiSense device, and then pulmonary vein isolation. That procedure has been modified a lot. So, I think it would be nice if you can kind of talk about the lesion sets we do that, people will term the convergent plus or plus procedure, and why that may be associated with even greater benefit than what we saw in the Converge study.
Yeah, so basically what you're trying to refer to is, as I showed in the video, if you looked carefully, was the main goal of the convergent procedure is to ablate the posterior wall of the left atrium between the pulmonary veins. But then we add ablations to those. We continue the roof line almost to the left-sided pulmonary veins, and also connected to the anterior portion of the left-sided veins all the way to the posterior wall. So it's almost 3/4 done. The only portion left is a little bit of the roof line and the anterior of the right veins. And then, as we just alluded to, the left atrial appendage portion is also added. So that in theory, we can assume that this will have slightly better results than what the original trial had achieved. And that's the goal we're trying to show with our data, hopefully soon.
Yeah.
All right, so let's see. The next question is there any role on antiplatelet therapy in younger patients that have undergone hybrid procedure and do not want to remain on DOACs or dual direct oral anticoagulants?
So patients who've had their left atrial appendage excluded in
Yes.
some.
And they don't want anticoagulation, so what about antiplatelet?
Yeah, I mean, again, it goes really based on the CHAS-VAS score. So if the CHAS-VAS score is 2 or greater in men or 3 or greater in women, then we typically would still recommend oral anticoagulation with favoring a DOAC. In terms of whether or not you can forego that, it's a class 2B indication now, based on the latest guidelines, because we don't have the data. In theory, aspirin may make sense in some individuals. It kind of would try and replicate some of the percutaneous appendage management data. For example, with the Watchman device, after you've completed your period of anticoagulation, then they're typically kept on single antiplatelet therapy indefinitely. Whereas with the other approved device that we have in the US, the Amulet device, that one, once they finish the 6-month, assuming satisfactory results, they come off antiplatelets as well. And so it's a bit of an unknown. Again, I think it's a discussion with the patient, but I don't typically will stop the DOAC and give an aspirin.
Yeah. I think that the message here is that, again, data is sparse in this specific area, and the fact is that there cannot be a definitive answer to this. It should be a discussion, and hopefully in the near future we'll have a lot more data to support one way or the other. What time is it? The next question, I believe, is what is the role of biomarkers such as NT-proBNP and troponin in the risk stratification and management of the patients with atrial fibrillation?
Yeah, that's a great question. I'll answer that one, I guess.
Go ahead.
So there's actually very nice data published in it was JACC. I think it was 2011, 2012, looking at the role or the impact of biomarkers for stroke prediction in patients with atrial fibrillation. So we use a CHAS-VAS score. That's what's in the guideline. It's an easy score to use, but it's not a great score. If you're familiar with the C statistics in terms of how predictive it is of events, it's not great. It's something like 0.67. And so it's very good for identifying patients who are truly at low risk, I think, but it's not a great predictor for everyone. And so biomarkers have been shown to improve that predictability much greater. It's not used routinely because, it's a blood draw and expense, and it makes the classification a bit harder than just using the CHAS-VAS score. But if patients do have elevated rates of either NT-proBNP or high sensitivity troponin, then it's been shown that those will affect the stroke risk above and beyond just the CHAS-VAS score. And so I've used it on some occasions, usually when there's been a bit of equipoise with respect to the patient's stroke risk, and they've really wanted to know, as much as possible, one way or another. For example, to try and come off a blood thinner or remain on it. We obtain those and help guide the decision in discussion with them again.
Fine-tuning.
Exactly. Yeah. Yeah.
Excellent.
But there are a lot of other things that contribute to stroke risk that we don't incorporate, other comorbidities outside of the CHA2DS2-VASc score, the type of atrial fibrillation someone has. So
Yeah.
even though we anticoagulate them, irrespective of whether it's paroxysmal, persistent, long-standing, persistent, there is data that suggests those who are in, persistent atrial fibrillation have a greater stroke risk than those who are in paroxysmal atrial fibrillation. And so there's studies as well ongoing now trying to tailor the anticoagulation regimen whereby, with these expanded wearables and better identification of AFib, can you streamline the therapy to take it only when needed rather than always taking it?
Great point. So if you have any other question, please send it in. I'm going to ask you one more question. We have a little bit of time left. So if someone is listening to this, what would you say would be a typical patient that you will refer for this procedure, for the hybrid procedure?
Yeah, good question. So we get a good number of referrals for this. Some people are good candidates and I think would benefit. Others, we have a discussion with them. Typically, I would say patients who have what I would perceive as being very difficult to treat atrial fibrillation from a either drug or catheter ablation perspective, who want to do as much as they can to maximize the chance of staying in normal rhythm long term. I tell them always that this is not a cure. I tell them that you may need more than one procedure beyond the hybrid. But the typical patients that I would get referred and I think are good candidates would be those who have long-standing persistent atrial fibrillation, as we discussed, those with very large left atrial dimension. The example you showed of the young lady with the restrictive cardiomyopathy, that one was referred to us as, for a hybrid procedure, but we felt that even with that, it's not a good option, which is why we discussed doing a surgical ablation. Patients who have had prior ablation, typically we ask for at least 2 prior catheter ablations, and if they're still having atrial fibrillation, not atrial flutter, but atrial fibrillation, we would then consider offering this procedure. And all other things. I mean, we emphasize the importance of risk factor modification. It's for some people it's easier to do the procedure than modify diet, exercise, lose weight, but all of those things are actually class 1 indications in the guidelines. They carry higher level of evidence than what some of the invasive procedures have, and therefore should be done. So emphasizing all of those to really try and maximize the likelihood of success long term. But it's typically those with longer standing persistent atrial fibrillation or have failed multiple previous catheter ablations, or if there is a good reason to for them to try and come off the blood thinner because of bleeding and stuff, so we can consider clipping at the same time. But that in itself is not a reason to do it.
Great.
Okay. So maybe while other questions come in, I'll ask you in terms of you talked about some of the contraindications, but what are some of the patient level factors that make this procedure maybe more difficult or risky for you, that you may not be as enthused to offer a hybrid ablation versus another form?
Well, we've made it fairly safe procedure, as you know well. So short of those contraindications, I would say body habitus is one thing that we look at. The higher the body, the BMI, any type of surgery, specifically this type of surgery, will be a little bit more challenging. If there's any anomalies, obviously that will be taken into consideration. One of the big things that I make sure I look at is any other indication for a cardiac procedure. So if the patient has mitral valve disease or mitral valve regurgitation or severe tricuspid regurgitation, as you mentioned, these could be a side effect of a long-standing persistent atrial fibrillation. Then you may have a different discussion. Or if the patient has coronary disease, you may say, okay, well, you may benefit from a bypass surgery or a valve surgery, and we can offer the ablation procedure for the AFib during that during the open heart surgery. But if none of those exist, then I think the the hybrid procedure becomes much more relevant. Now, the other thing I wanted to mention is also, for those who haven't heard of how this is done, you saw a quick picture and a video of it, but basically it's a 3 or 4 little side holes on the left side of the chest, and the patient wakes up with one chest tube, and they usually stay in the hospital about 2 nights. And there's some restrictions when they go home, but it's not very much. So it's a fairly light procedure in terms of its duration, and it's designed to be as minimally invasive as possible.
Yeah, no, I think that's a very important point to highlight. As we've gained experience with this, there was, I would say, a slight learning curve
Absolutely.
with this, and with more experience and refinements to the technique. You mentioned the robotic that you like a lot. Recovery has been quicker. Pain control is very important for this. So if you think about what we're doing, we're incising the pericardium and then we're burning the back wall epicardially extensively. So there's a big inflammatory reaction after this. And so it's really important to stay on top of pain control for these patients with, things like colchicine, non-steroidal anti-inflammatory drugs, because that will really help improve their recovery.
Yeah.
And staying ahead of that really does make a difference for that. And the vast majority do very well with that. It's not uncommon for patients who've had, as you know, who've had the first stage, that they still have atrial fibrillation while awaiting the second stage. And we always tell patients, don't be surprised if that's the case. In fact, it's probably more common than not because of, again, the inflammatory reaction and everything. And so typically they'll be on an antiarrhythmic drug to help keep things calm for that time frame. But it's really only after the completion of the lesion sets, whereby we do the pulmonary vein isolation in completion, we can finish the roof line. The reason is that way we get more extensive posterior wall isolation and then target any other inducible arrhythmias, atrial flutter or whatever, that we hope for longer term success.
Great.
Any other questions?
No more questions in the chat. Any other closing remarks?
No, I hope this has been helpful. Again, atrial fibrillation is a massive problem, within the US and worldwide. It's only anticipated to get more problematic, and so having various treatment options is important. And we just wanted to present a slightly different spin to the management, whereby there's really close collaboration between cardiology, electrophysiology, cardiac surgery to optimize and streamline the care for these patients. So if you have any questions, please don't hesitate to contact us offline, and we'd be happy to assist in any way.
Yeah. Thank you.
All right. Thank you very much.